This is our own music. Hello, I'm Dr. Lynda Young, and welcome to Health Matters, a television program produced by the Worcester District Medical Society and WCCA TV. Today we have a wonderful person that is my guest today, and that is Dr. Tiffany Moore Simas. Dr. Moore Simas is the chair of the Department of Obstetrics and Gynecology at the University of Massachusetts Medical School and UMass Memorial Healthcare. She's the founding engagement director of the Massachusetts Child Psychiatry Access Program for Moms, fondly known as MCPAP for Moms, and is also medical director of Lifeline for Moms, and we are going to hear more about these programs in the next few moments. On the national level, Dr. Moore Simas serves on advisory boards and expert work groups and has been recognized for her work addressing mental health in pregnancy and postpartum care. So welcome. Welcome, Tiffany. Thank you for joining me. And I know you have some very interesting things to catch us up on. So my first question to you is, how common are mental health problems in pregnancy and after pregnancy?
Yeah, so that's a great question. They're actually really incredibly common. And if women... Often women are aware of something called postpartum blues or baby blues, and that affects about 80% of women. So if you have 5 women, 4 out of 5 of those women will experience baby blues.
Wow.
And so that is an experience some women or birthing persons experience immediately following the delivery of the baby within those first 2 weeks. So not necessarily within minutes or hours, but those first days to 2 weeks following delivery of the baby. And that's incredibly, incredibly common. Mm-hmm. If you think about mental health conditions more broadly in both pregnancy and the postpartum period, historically we talked more about depression. And we would say that affected about 1 in 7 women in pregnancy or the postpartum period. But if we expand that to more mental health conditions like anxiety, obsessive compulsive disorder, or OCD, post-traumatic stress disorder, or PTSD, that's more like 1 in 5. And I have to say those numbers are really pre-COVID pandemic.
Yes.
If we think about what the COVID pandemic has done to mental health in general for everybody, not just in pregnancy and postpartum, the mental health experience of mental health complications is up for all persons, and pregnant postpartum persons are not excluded from that.
I was going to ask about that because, as you know, I'm a pediatrician, and the mental health problems in kids during COVID, so I would imagine same sort of thing for women that are pregnant. Yeah. And you mentioned postpartum, meaning after delivery. Is there a time frame for that, or is that like forever?
Yeah, well, most parents might say forever, but the postpartum period is really considered from the time of delivery to the when that child turns a year old. So that first year after the delivery of a child. And I'll often use the term perinatal, which encompasses both the 9 months of pregnancy, the labor and delivery, and the 1 year in the postpartum period. And, historically, when we talked about mental health conditions affecting pregnancy, I think postpartum depression is mostly what people talked about, and really thought about it as occurring after the delivery. But now we know that birthing persons experience much more than just depression, and B, it's not just after the delivery. So if you actually, screen women for these conditions, at the start of pregnancy, towards the middle or end of pregnancy, in the postpartum period, you see about an even distribution between, a third of persons whose pregnancy or postpartum period is affected by mental health. They kind of came into the pregnancy with it, whether they knew it or not, and whether their doctors knew it or not. About a third develop it over the course of the pregnancy, and then a third have that postpartum onset, so after delivery.
So when you mentioned depression, How would somebody know that they have a problem with that or any mental health thing?
So
And
it's, yeah.
I was just going to say, and mental health has such a stigma to it that, but it's an illness that needs to be recognized and treated as such.
Absolutely. It is an illness that needs to be recognized and treated as such. It is an incredibly common illness in pregnant and postpartum women and other, birthing individuals, and it's very treatable. And it is more treatable the earlier we recognize it. So knowing this, a lot of the professional medical societies like the American College of Obstetrics and Gynecology says we should be screening everybody in pregnancy and or in the postpartum period. And that screen is really using questions that are standardized questions that have been shown in studies to pick up these conditions. And we shouldn't just say, oh, let me screen this person, they look depressed, or let me screen this one, but not this one. We should do it for everybody. And part of that is decreasing that stigma, is saying everybody is at risk for it. We should screen everybody. I'm going to ask everybody because I care and because I can help if there's a problem.
Yes, absolutely. I think that is so important, that it's people that will say, well, there's a shame to it, or there's nothing you can do about it. Right. And I think that's such a disservice, certainly to the mother, for the child, and the family, spouses, etc. So
I think you're absolutely right. And I think that is true of mental health across the board, that there's stigma associated with it. And, I'm biased as an OBGYN, I think, but I also think there is increased stigma in pregnancy and the postpartum period, because there's this general sense of it should be the happiest time of your life. You should be so excited. You're having a baby. It's also one of the most stressful times in your life, anxiety provoking, and the hormonal changes, the social changes, sort of who you are as a person, now caring for this other person. There's a lot of stress. There's a lot going on there.
If in your experience with patients, how aware are the patients that this might be a problem?
That's a great question. I'd say, like anything else, it's highly variable. So we'll have patients whose mothers or sisters have experienced mental health complications of pregnancy in the postpartum period who are very aware. We have patients who come into it with a known mental health history, which either is already being treated, or they're aware they've had something in the past, so they're worried about having a new onset or an exacerbation of their existing mental health conditions, and others who really just don't know. I've talked to many a women who, after coming through it, saying, I just had no idea. Why don't we talk about this? And my own work in sort of merging obstetrics and mental health has been well over a decade in process. And fortunately, I think we hear much less now about the why did nobody tell me about this? Why didn't we talk about this? So there's much more attention that has been brought to it in the past decade. But really, it was a thing, as you said, stigma. People just didn't talk about it.
Right. And I think that, and you're probably well aware of this, that oftentimes when the mother's goes home from the hospital after she's delivered, she doesn't see you for 6 weeks usually. But boy, she sees the pediatrician. And the pediatrician is seeing that baby within the first week.
Right.
And so I'm a pediatrician, and we are trained to ask those questions also. And as a matter of fact, you had mentioned the American College of OBGYN. The American Academy of Pediatrics also has a lot of good policy about asking about that. So I think it's getting a lot, well, it's been a while, though, that we've had to do that. So, but it's so important.
It's so important. And, our pediatric colleagues are such amazing partners in this, because as you mentioned, I may not see the woman face to face until 6 weeks postpartum. There is a recommendation that we have a check-in at like 2 to 3 weeks, and that may just be a phone call. But beyond that 6 or even out to 12 weeks, there's now a term called the fourth trimester, which are kind of the 12 weeks after you deliver, which there's so much going on in that time. But often it's like you had a baby and then you went home. And so people are more and more recognizing what is obvious now, which is there's a lot going on there. We should pay more attention and provide additional care there. But beyond those 12 weeks, often people, birthing persons will, return to whatever care they were having before the pregnancy. And so that may be seeing their internal medicine doc, their family medicine doc, whoever is providing their care. And for a lot of young, healthy persons having babies, that doesn't involve a lot of care. And so the pediatrician is critical, not just in that when they're seeing the baby at 1 week, 2 weeks, 1 month, 2 months, but the pediatrician has those regular visits throughout that full postpartum year.
Right, that whole year, yes. So I think it's important that we know that that's another venue that's very important for the families.
Absolutely.
And certainly for us. So it's important to see that and notice it. What do you do for these? What are the things that you use as far as treatment goes? And going a little further than that, what are the risks of those treatments?
So another great question. And that, I guess I would start by saying it depends. Right? It depends on what condition we're talking about specifically, whether it's, depression, anxiety, that OCD, PTSD, bipolar disorder. It depends on the condition and the severity of the condition. And so I would say the mainstay for everybody is there's a role for therapy. And so therapy has really no risks associated with it and a lot of potential for benefit when one engages it. And then depending on the severity of disease, the history of the person who has the mental health condition, family history, personal history, whether they've had it before, whether they've taken medication before, and what their desires are for treatment. There is a role for medication for many persons. And I know there's always this concern around medication in pregnancy and lactation. And so when I talk to pregnant postpartum persons around whether or not a medication is appropriate, the conversation is not what are the risks of the medicine. It's really what are the risks of untreated mental health disease versus treated mental health disease, because we know there's risks of not treating this. Right? There are risks as it relates to pregnancy outcomes, low birth weight babies and preterm delivery. There's risks as it relates, of course, to the mother, her quality of life, the severity of the disease. For women who have severe disease, sometimes it's risk of, self-harm. And then there's risk to the baby for not treating the disease. And that, that mother-child interaction is incredibly, as you know, as a pediatrician, is incredibly important in developing the healthy foundation for that baby and its emotional health and long-term mental health.
Definitely.
And so not treating disease comes with risk. And then the risks of medication, honestly, somewhat pale in comparison, right? And so people worry about that a lot, but it's a real conversation around what that means. And almost always the right thing to do, or the path to a healthy baby, is a healthy mom.
Absolutely.
And so making sure mom gets the treatment she needs is incredibly important.
So you had mentioned a term lactating. What is that?
Yes, so breastfeeding.
Okay.
So a breastfeeding mother or person is a lactating person. And so there are some medications that will travel into the breast milk. And so when you are both pregnant and lactating or breastfeeding, you need to think about what, if anything, gets to the fetus or the baby.
Right.
And there are some medications that are used to treat, depression, anxiety, OCD, PTSD, that have a very, very low, what we call translactal passage, and so very low passage through the breast milk.
So you mentioned a couple other diagnoses that we hadn't heard of, the OCD and PSTD. Can you define a little bit more? Yeah,
so OCD is obsessive compulsive disease and PTSD is post-traumatic stress disorder. And so when, a pregnant or postpartum person experiences a mental health complication of pregnancy, as I said, historically, most people talk a lot about depression, but there are a lot of other mental health conditions that they can experience also. And so, as I'm counseling persons, I often will stay away from a title or a diagnosis, especially as I'm talking to, pregnant persons and their partners and thinking about what to look out for, whether it's in pregnancy or at the time of discharge from the hospital after the delivery. And, I will very simply say, if you are worried about what you're thinking and how you're feeling, that in and of itself is enough to give us a call, and then we can use those screening questions to help walk through what it might be.
I think that's a good rule to follow for us. So excellent. I think that the treatable conditions are so important for people to know about, and the safety of the medications. Because most mothers that are nursing are very, very careful about what they eat, what they drink, what they take. So I think it's so important to, and I know you all go over that when you prescribe them.
We do, and it's also really important for persons who come into pregnancy on medications to address their mental health needs, not to just say, oh, my pregnancy test is positive, let me stop everything. Because we see that a lot. It's important to call and have a conversation, because I think oftentimes what people are worried about is actually not a concern, and often don't take into account the effects of untreated illness. And are just worried about the medications. And, everybody worries about the medication, but, we talked about therapy is a really, really important part of treatment. And then there are other, adjuvant treatments, other treatments that we can use in addition to that, which focuses on things like, self-care, meditation, deep breathing, small daily goals or attempts at pleasurable activities. There's all of this sort of contributes to helping.
And I think, again, all those are important points and hopefully are taken to heart by people that receive that information. So I promised in the introduction that you were going to tell us about those two programs. I'm familiar with MCPAP as starting as pediatrics, but it's also, you are very involved in it for moms. So I'm going to have you start with that, and then I want you to tell me about the I have it in my notes here, Lifeline for Moms.
Okay, I'm happy to talk about those. I think they're really exciting, and I think have really changed the landscape and the ability for pregnant and postpartum women to get care that they need. So MCPAP, which is the Massachusetts Child Psychiatry Access Program for Moms, which you know very, very well, Massachusetts Child Psychiatry Access Program, period, the child program, started almost 20 years ago in Massachusetts, which it was developed to address the need that there were never going to be enough pediatric psychiatrists in the state of Massachusetts to address the mental health needs of the children of the Commonwealth.
I should mention it started at UMass.
It started at UMass, that is true. And so it was this great program that through, trainings and consultations by phone with pediatric psychiatrists and with the, sort of creation of resource and referral networks, meaning being able to connect pediatricians with resources for their patients, the kids and their parents and their families, were able to connect them with care for mental health conditions. And so fast forward about 10 years later, after the child program was created, it was recognized that we were sort of in a very similar situation. There was growing attention nationally and certainly in our own state to address mental health conditions of pregnancy and postpartum, and there was this real push to screen women or pregnant and postpartum persons for these mental health conditions, which is the right thing to do. However, it's not enough to screen somebody and say you have this mental health condition. You really want to connect them with care. And there just wasn't those resources in place to do that. So I, as an OBGYN, could do a screener and say, it appears that you're having some depressive symptoms. How are you doing? We go through whether or not her quality of life was affected, whether or not she needed treatment. And then it kind of stopped there. Because historically, OBGYNs have not been trained to address mental health. Certainly when I went through, all my training, it was not something we talked about. And so I had little to no comfort around treatment. And so MCPAP, what is now MCPAP for Moms, looked to the child program and said, there's never going to be enough perinatal psychiatrists, so psychiatrists that are specially trained in pregnant, postpartum, and lactating persons. And even there just aren't going to be enough psychiatrists in general to address the needs of pregnant, postpartum, and lactating persons. And even the general psychiatrists that are out there are often uncomfortable with pregnant, postpartum, and lactating persons for all the reasons we just talked about, or concerns around medication. And so the MCPAP for Moms program was born. Nancy Byatt, who's a perinatal psychiatrist, good colleague of mine, really is the founding medical director of that. And it is a three-pronged program that really the goal is to increase the capacity of frontline providers like obstetricians to address perinatal mental health and substance use disorder. So through the creation of toolkits and training of obstetricians across the state, through a 9 to 5 Monday through Friday phone line in which if I have a woman in my office I'm worried about, I can pick up the phone and call and talk directly to a perinatal psychiatrist to get their input on help guide me, help teach me on how to care for this person. If it is something that even after that conversation I feel uncomfortable, I'm not sure what to do, or the psychiatrist says, you're right, this sounds really complicated, we should see this person, they will do that that consultation in very short order. And then there also is a live active inventory of all behavioral resources across the state. So again, if I have a pregnant woman in my office who I'm worried about, who I really get to get connected to therapy, and I know her insurance and her zip code and her language preference, and they'll give me resources to help connect her with care. And all of this happens in a very short time period, which is great because in pregnancy we have 9 months to really make a difference.
Yes.
And same thing in the postpartum period. I'm sure you would argue with that newborn. We have 9 months, or we want to move quickly on helping get parents better and helping the children too.
Yes, it's a game changer. It was certainly for when MCPAP came around for kids.
Yeah.
So excellent.
Yeah.
And how about the other program you're very involved in?
Yeah, so MCPAP for Moms was the first of that type of program in the country. And so Massachusetts had the first statewide program to help frontline providers address perinatal mental health and substance use disorder. And we have some real great legislators and advocates in our state who looked at this program and said, it's really making a difference. And brought forth federal legislation, which was sort of signed into law through 21st Century Cures, to allocate monies through HRSA, which is the Health Research Service Administration.
Yes, I can't remember what
it
means.
I use so many acronyms,
Yes.
I sometimes forget what they mean. And so HRSA funded 7 other states to create similar programs.
Wow.
And then other states, through various funding mechanisms, have also developed similar programs. And so Lifeline for Moms, we founded here at University of Massachusetts to help network all of these programs together so that everybody can learn from each other, so that everybody can share what's really working, where we can make improvements. And so we're really it's such a great community of persons that are really dedicated to addressing these needs. And then, Lifeline for Moms, that's what we call the Lifeline for Moms network. But as part of the Lifeline for Moms Center at UMass, it's also where we do, research and advocacy and anything we can really do to further, integrate mental health obstetric care and really advance every effort to make sure that there's no pregnant, postpartum, lactating person that feels like, I didn't know this could happen, and I experienced it, and nobody helped me. Our goal is for everybody to get the help they need.
Yes, and I think, and as you very nicely brought out, it's so important to work as a team, but also to expand this out. So you're looking at people that are in rural areas, in urban areas, all over different places, and looking, I'm sure it captures a lot of disparities of health.
Absolutely.
Where you can identify other problems in addition to these, which you then can get resources for because you have a volume of people that you can work with. That's so important, and I think it's important for us to know all of that.
Yeah, well, it's so interesting. In Massachusetts, I'm often humbled by, when we struggle with getting our patients the help that they need. We're in Massachusetts where there are so many medical resources, and if you look at the number of doctors, practices, hospitals per person, we're very, very fortunate. In our network, we have, the states of Montana, and, where there's, maybe one perinatal psychiatrist in the entirety of the state.
Right.
So when you think about, partly, this network really brings together people who are doing the same work in very different ways, in very different circumstances, and so we really get to help brainstorm with each other on how to do it better for everybody.
And I think, too, COVID certainly has brought out telehealth, and this is a perfect way to get even more people help with this, because you're able to, like in Montana, It may be a 12-hour drive to go see somebody.
Absolutely.
So I think that that's really very encouraging and very exciting that you can use these different digital platforms, so to speak, to help people instead of having to actually go physically to see somebody. So I think that's very exciting. So I always like to look at, so you have this problem, is there any way to prevent it? Is there any way, could we offer whatever it is to say, let's prevent this from happening instead of treating, let's prevent?
Yeah, so a couple things come to mind with that. One is the U.S. Preventative Services Task Force actually has a recommendation around this. There are 2 interventions in particular that have demonstrated effectiveness in preventing postpartum depression is what they looked at specifically, onset. And both of them were therapy-based programs. And so when you enrolled women who are at high risk of developing postpartum depression in these programs before they had onset, so that it was intended to prevent it. And in fact did so in about half of those women. And both of them were sort of group-based, therapy-based interventions. And so that is one potential for prevention. The other is, and this is not sort of evidence-based, we haven't studied it, but I do think that just in general, education about this, decreasing the stigma, allowing persons to, educating them about them, allowing them to talk about it, making sure family and friends are aware of it, and supporting the pregnant and postpartum person is really incredibly important.
Yes, that's very exciting to know. And it is nice to know that some people probably would kind of balk at that and say, oh, that's not me, but it's there and it's offered.
Yeah.
And I think that's important for them to know about. Yeah. Anything else? We are almost out of time, but anything else you'd like us to know about in the next few minutes, or a few seconds, actually?
The one thing I would add, which is just, this is somewhat futuristic, although I hope not too far in the future, is more and more we are really recognizing the role of social and structural determinants of health, and the role of racism and disparities in care, and how all of those things contribute to the mental health burden disproportionately to some more than others. And so I think in some point in time when we think about health, we will have a much broader, holistic definition of health and addressing, housing insecurity and food insecurity and all of that.
Definitely. Well, thank you so much. This was really interesting, and I'm hoping people have understood what's out there for them and the resources that are available, and I appreciate you coming and being with me today. So thank you very much for listening. This is Dr. Lynda Young for the Worcester District Medical Society and WCCA TV. Thank you.